All right, so let's have a look at lungs. The easiest place to obtain a view of the lung is on the anterior chest, and uh, you can place the probe just in between a couple of ribs with the probe marker facing towards the patient's head, and you should be getting a view similar to what you see on the left here, where you have a rib shadow on either side, and then you can see this repeating pattern of white lines. You may or may not see the repeating pattern, but there should be a white line there um, at the top. And the repeating pattern of white lines that you see here, these A lines, is just basically a reverberation pattern where the ultrasound waves are bouncing back and forth between the surface of the lung and the surface of the probe. And that only happens with well-aerated lung or with a pneumothorax. So you need a surface of air for this reverberation to occur. And it doesn't always happen. Your probe has to be fairly perpendicular to the surface of the lung to get that pattern to show up. But when it does show up, it effectively rules out parenchymal disorder of the lung in that spot, because when you have too little air in either the alveoli, which could be caused by fluid or some other buildup in the alveoli, or some buildup in the interstitial space, then you won't get A lines. You need enough air in the lung to get A lines. This is another normal thing that you'll see. As they breathe, you should be able to see this sort of twinkling appearance. People sometimes refer to it as ants on a log. This is where the interface of the parietal and parenchymal pleura, where they rub up against each other, and it creates this twinkling sort of appearance. So that's normal, and that effectively rules out pneumothorax in that spot where you placed your probe. Earlier we saw A lines, which represent well-aerated lung, or you could think of it as drier lung. Here we're seeing B lines, these lines that look like little sort of sunbursts that shine all the way down to the bottom of the screen. These are called B lines. And B lines you can equate with a wetter lung. So if you have someone who has dyspnea, then this would start to increase your suspicion for congestive heart failure, ARDS, early pneumonia, or interstitial lung disease. So there's some reason for fluid to be in the interstitial spaces specifically in this case, or when you see these B lines. And this would decrease your suspicion also for pneumothorax as the cause of dyspnea. In fact, it effectively rules out pneumothorax in that spot because you need actual lung tissue right up against the wall of the chest in order to produce B lines. So you definitely do not have pneumothorax in that spot. And it also would decrease your suspicion for COPD or asthma or pulmonary embolism as the cause for your dyspnea. So this is an example of lung sliding and then no lung sliding. So when you see this is called a lung point. This is pathognomonic for pneumothorax. It's the point at which the air is first observed in the pleural space. So with the lung, kind of putting things together when you're looking at lungs, you have A lines and B lines, and A lines and B lines can tell you how wet or dry your lung is. If you have more A lines, you're thinking drier lung. If you have more B lines, you're thinking wetter lung. So these can rule in pneumonia when you have lots of B lines and no A lines, pneumonia or ARDS. Lung sliding tells you that you definitely do not have pneumothorax. If you can see lung sliding, that's by definition that's parietal and parenchymal pleura rubbing up against each other. And so at that spot where you have placed your probe, you definitely don't have pneumothorax. Similarly, a B profile, if you have those B lines, you know that that's lung tissue right there. So you don't have a pneumothorax there. You're unlikely to see that with COPD or asthma or pulmonary embolism as the cause of your dyspnea. Now, if you have a B profile and you have lung sliding, then this really pushes us towards more of a cardiogenic pulmonary edema. And the reason is, if you contrast that with a B profile without lung sliding, that's usually caused by some inflammation that's causing the pleura, the parietal and pleura, to kind of stick together. If you lose your lung sliding, those two serosa are kind of sticking together, and so this happens in states of inflammation like pneumonia. But in cardiogenic pulmonary edema, you don't have inflammation of the surface of the lung, and so you can still slide well, and so you still have lung sliding. And just to give you a sense of how useful this actually is in clinical practice, the sensitivity and specificity of ultrasound as compared to using CT as a sort of a gold standard for diagnosis. The sensitivity and specificity are quite high for ultrasound for a number of common lung problems, so pleural effusions, alveolar consolidation, interstitial syndromes, complete pneumothorax, and occult pneumothorax, are all detected well and can be fairly well distinguished from one another using ultrasound.